Hello everyone. Just want to welcome everyone in. Let's give folks a chance to get settled in virtually before we get started here. Still see there are a few trying to get connected to their audio, so let's give them a fighting chance to do that. Great to see some familiar names and faces in the audience. And everybody hear me okay? That's wonderful. And you should be seeing the introductory screen here. Still a few trying to connect. Looks like Alicia's still trying to connect, and Willamette is still trying to connect.
Okay.
Let's give folks a chance here to get plugged
Okay.
in. I see Clem is with us. Clem, good to see you. And Frank is here. Good to see you, Frank. And I see some other familiar names as well. Deborah, welcome. Good to see you on. Okay, well, let's see. Looks like just about everybody's plugged in. We may get a few folks joining a little bit later, so we'll keep the wait room disabled so folks can come right in and join us when they can. So
Okay.
just want to welcome you all to another installment of our essential substance abuse skills training, and want to again, just as a reminder, this we're going to cover a lot of information, and I know that some of you are practicing already and may know a lot of this material. So for some of you, it may be a review, and for others, maybe just entering the field or interested in entering the field, this might be a good introductory module for you to be part of. So just wanted to put that out there, and I think we're going to really try and encourage folks to unmute and share any thoughts or comments, questions they have, and if we need to just pause the slides and have a discussion, we can do that. So really glad you're all here. It's good, like I said, it's good to see some familiar names and faces. We have Dr. Esas Garcia here to present today on treatment knowledge. And again, this is going to be sort of a mixture of Western views, and then what Dr. Garcia will bring to the table is some of her own cultural perspectives, and we'll sort of mix the two and compare the two and how they interface. So really happy to have Avis here with us today. She is a colleague and a friend and has been a consultant and part of our consultant group for, gosh, I think it's been at least 3 years, Avis, if not a little bit more. So really happy to have her here. I just have a few introductory slides I'll go over. My name is Steve Steiny. I'm one of the program managers here at the American Indian Alaska Native Addiction Technology Transfer Center. So I've just got a few introductory slides that we'll share, and then I'm going to turn the floor over to Dr. Garcia. And as I'm transitioning and getting the main slide deck up, I'll let her talk a little bit more with you about her background. So just bear with me as we do a few introductory slides, and then we'll jump right into today's broadcast. So again, glad to see everyone, and I want to welcome you all to the Essential Substance Abuse Skills Training. Treatment knowledge is today's topic. As most of you know, this event is brought to you by the National American Indian Alaskan Native Addiction Technology Transfer Center. We are located at the University of Iowa. We are part of a national ATTC network, including 10 regional centers, a national Hispanic and Latinx center, as well as an ATTC network coordinating office at the University of Missouri. You have to pardon me, I'm fighting a little bit of a cold, so if my voice kind of sounds funny, that's what's going on. So just want to apologize in advance for that. As most of you know as well, this project is supported and funded by SAMHSA. The content is developed by the presenters, and the opinions expressed today do not necessarily reflect the views or policies of SAMHSA, HHS, or the National American Indian Alaskan Native, ATTC. And again, sometimes I feel like a broken record, but having done several of these broadcasts, I just want to remind everyone that we will provide to you following today's broadcast. We're going to reach out to you via email, and we will include in that email an opportunity to request CEUs. We'll offer 1.5 NADAC approved CEUs for this broadcast today, as well as links to the recording of today's event and any slides in PDF format that we can share. We will do that as well. And you'll also see an opportunity to complete a short survey. I'm going to post that link to that survey as well in today's chat box, but this email will give you another chance to complete this short survey. Your feedback is really important to us. This is a confidential survey. It can't be linked to you in any way. You can skip any questions you would like, and if you have any questions for me about this survey, please reach out to me here at our center, and I'm happy to talk with you about that. But we'd love to hear back from you. It helps support future events and lets our funders know what we're doing with their funds. Before we get started today, we would like to take a few moments to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a few moments to read this land acknowledgement that was created by 3 former members of our team, Ella and Keely Driscoll and Mr. Sean Baer, from the Meskwaki and Winnebago nations, respectively. Thank you. Well, without further ado, before I introduce our speaker, I just want to remind everyone that you're currently muted. But if you would like to make a comment, please feel free to unmute. You can use the hand raise feature or the chat box. I'm going to try and watch the chat box as we go today, and we're going to try and reserve a little time at the end to take some questions. But if we need to stop and process or talk a little bit, we'd love to hear from you. And as I said earlier, some of you have a vast amount of clinical experience and lived experience and can contribute to this presentation today as well. So we just want to acknowledge that, and we know that there are many experts among us today. So with that, I want to introduce today's speaker.
Hi, Cynthia. How are you?
Avis Garcia, someone's got an open.
Turn down this training quick. Hold on. I'm just going to turn it down.
Somebody's got a open
Okay.
mic, so
Yeah.
I'm going to ask you to please.
All right. Well, that's a perfect place to park.
Well, I didn't know, there's a good chance her 2 o'clock will show up, so.
Yeah.
I just thought, I just want to talk to somebody real quick.
I can't figure out who that. There we go. I got her.
Okay.
I got her. Wow. I was trying to find that open mic. So right on cue. Just please try and keep your yourself muted during the presentation. This is what can happen sometimes. It's part of the Zoom world that we're trying to navigate. So without further ado, I want to introduce Avis Garcia. She is a colleague and a friend. She is an enrolled member of the Northern Arapaho tribe and is affiliated with the Eastern Shoshone tribes of the Wind River Reservation in Wyoming. I know she's currently residing in Montana, but I think is going to be headed back to Wyoming, if I understand that right. Avis is a licensed professional counselor and an addictions therapist. She has got a lot of experience, over 20 years of experience, and she also holds a doctorate in counselor education and supervision. As I said, she's been part of our consultant group for some time. We are thrilled to have her on today, and as I get the next slide deck up, Avis, I'm going to let you talk a little bit more about what brings you here today to present for us. Thank you.
Okay, somebody's posting they can't hear.
Okay, let's see. Marilisa, yeah, you may want to just check your audio settings. There is a small down arrow next to your mute button. You may be able to boost your volume using those audio settings, or perhaps boost the audio settings on your device. Are others hearing us okay at this point? Okay, I've got some thumbs up. So yes, I would just say, Mary Lisa, just check your audio settings and see if you can't boost the volume a bit. Okay, Avis, I'm going to stop sharing the introductory slides here while you say hello to everyone.
Okay, good morning, everyone. You just cut me off. I don't see the screen. Can you guys hear me?
Yeah, I'm just transitioning. Okay. I'm getting the next slide deck.
I am, as he said, I'm a member of the Northern Arapaho tribe, and my father was Eastern Shoshone. So on my reservation back home, we refer to ourselves as show reps, which means we're both tribes. Those are the 2 main tribes of the Wind River Reservation in Wyoming. However, I am currently broadcasting live to you from Crow Agency, Montana. I am now the clinical supervisor for the Crow Tribe's substance abuse program. So I have been here for a while now, and as Steve mentioned, I am planning to return back to my reservation area in the spring time to provide services on the Wind River Reservation. So I'm kind of looking forward to that. I have been in this substance abuse field for 21 years now. I can't believe I'm saying that every time I say that. I have been doing a lot of substance abuse work in the field. So I appreciate all of you that are here today to participate in the Essential Substance Abuse Skills webinar. I have been doing webinars and trainings for the addiction technology transfer since 2019. And I like to do these because I like to teach, and I just enjoy sharing all this information that will help those of you who are about to sit for the exam. So if you're preparing for the exam, We do these every month on some topic area that will be on the exam wherever you are. And we also do a training that is it 3 days? We travel to different parts of the country, or 3 days to provide those live and in person. So I know we
it's
have a couple.
It's a
We have a-
4-day event.
Yeah,
4
we
days.
have a few of those coming up in the next couple of months in different areas. So like I said, I just enjoy doing this. So that's why I do it. So today's objectives are, as you can see there, to get a better understanding of what evidence-based practices are, best practices, promising practices, understand the importance of building the treatment alliance and becoming familiar with more commonly used evidence-based and best practice approaches in your work, better understanding what co-occurring disorders are and integrated care, and we will dive into a little bit of the medication-assisted treatment. Okay, we can go to the next slide. Evidence-based practices. These are methods and techniques that have documented outcomes that they're able to be replicated and are often recognized in scientific journals and published. There are also the TAPs that are manualized by SAMHSA. And so these are the highly researched practices that quite often don't include any Native Americans, is what I find in my personal research. But we are required to use these in our work because a lot of the funding sources will require us to use evidence-based practice, but we'll explain how those apply to treatment work. A best practice is a method or technique that's consistently shown results superior to those achieved by other means. So these best practices, I like to say, are also our traditional cultural practices that we know help our people as well. They're just not a lot of research done on them to say that they're evidence-based. Promising practices is generally described as having a body of evidence with some research or some expert consensus about the efficacy of using those practices. And we can go to the next slide. Characteristics of substance use disorders. The American Society of Addiction Medicine, ASAM, describes the characteristics of addiction as an inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. So the ASAM has criteria that they look at to make a diagnosis, and this ASAM is what helps us to determine the treatment placement of the individual that you will be providing services to, so that we can individualize that treatment to meet that person, their individualized level of care that will be needed. So we can go to the next slide. Our goals for treating substance use and co-occurring disorders: to properly assess the patient using multidimensional tools, to provide integrated, coordinated, longitudinal care using evidence-based approaches, to provide an optimum opportunity for healthy behavior change through the therapeutic alliance, improve the patient's overall health and wellness, to measure outcomes, to provide informed consent, and also individual, family, and community recovery-oriented systems of care. Okay, we can go to the next slide. So what does all of this mean? What it means that it is our responsibility as treatment providers to improve service delivery and monitor patient outcomes. The field of substance use disorder treatment is evolving and will require a broader understanding of the term treatment. We have a responsibility to stay informed about evidence-based practices, best practices, and promising practices. Those in leadership positions have a responsibility to prepare and mentor the next generation of addiction professionals. As you all know, we have a shortage of people that are qualified to provide treatment services across the country. And we need to do everything we can to increase the workforce out there. Now we will talk about the therapeutic relationship.
April made a comment about ASAM. She said there's ASAM assessment in the ASI, and there is a native version. April, do you want to just share a little bit about that?
Well, I don't think I have anything extra to say, but that's what we use at the AS.
Okay, thank you. Thanks for sharing.
Yeah, our program here, we use AccuCare, and it has the ASI built into it. We also have the Native American cultural assessment that is built into it as an optional evaluation tool or an assessment tool. And I do know when I worked back home, I know they're still doing this, the White Buffalo Recovery for the Arapaho tribe. Every assessment that's done, they do use that cultural assessment form on every individual. Like your assessment wasn't considered to be a complete assessment unless that was completed as well. And what that tool looked at was language spoken, cultural practices practiced, the foods, basically looking at when you look at the dimension of cultural assessment from those that are strongly traditional, bicultural, or more fully assimilated into Western ways of society, and meeting the needs of those people that want to learn cultural stuff, because I have had some in my experience that don't want to participate in any cultural activities. And at the program where I'm working now, we have a cultural counselor on board, and we do provide that, but we do have some that just say, I don't want to do that. So we honor their wishes and not, requiring them to have to do it. But if they choose to, we like to make those accommodations available. Can go to the next slide. This is a quote by Steve Stein. You want to read that, Steve?
Wow, how did this get in there? I don't know. So you guys know I come from a clinical background. I spent 23 years working in the substance use disorder field, and this is something that I learned and experienced both as a patient and as a provider. The more we involve our patient in the decisions about their treatment process, the more meaning and purpose they will likely associate with their experience. It really speaks to me about a patient may not remember what you talked about. They may not remember the content. They may not remember the treatment plan or the goals, but they will remember how they felt when they were with you.
Mm-hmm.
And this is something that always drove my practice in when working with others who I was training to work with patients. So yes, thanks for letting me read. I've never read that out loud to the group before, so thank you, Avis.
As I reflect on this quote here, it really resonates with person-centered approach to working with people. And we are CARF accredited here at the Crow Tribe's Absolute Gay Healing. And they strongly and highly emphasize person-centered care. Like they want to see it in everything you do in your program. So this really resonates with that in allowing the clients to be the expert on their care. And so when I see someone, I tell them, what do you want? This is your program, and what kind of goals do you want to pursue? And I often ask my staff to directly quote our clients when making notes or writing treatment plans. If this is their words, please put it in quotations so their voice comes through. Thank you. The therapeutic relationship, the therapeutic alliance. This is the most important part of working with clients in substance abuse and mental health. It's important to develop rapport, have common or shared goals, and the number one thing is safety and trust. We just had a discussion this morning. We're planning to do some podcasting with a company, and we talked about how many of our Native people have been, I guess, traumatized, disappointed, let down, and they just have no trust. And so it's really hard to build trust with the clients. And so it's really the most important part of the relationship with working with your clients. They need to feel heard. And it's also where they come from. I've had gentlemen that I've worked with that told me, well, my dad said, nobody wants to hear your problems, you know? And so sometimes it's where they come from that they think they're not supposed to open up or share about themselves. So once they establish that safety and that trust, they will feel more comfortable and want to come back. We've tried to move some of our programming to another building, only for several of them not to go there because they feel more safe here, you know, and they've said that, do we have to go there? And I'm like, no. So sometimes those things happen in your work. So it's being able to be in tune with them through that alliance and helping them to have that. It is also our ethical responsibility to have a relationship with our clients. Again, not doing any harm, by giving them a lot of the power in the decision of what their treatment is going to look like. And also the power distribution. I come from a culture, or as an Arapaho, raised by my grandparents, that I'm to never put myself above people. I always put myself on the same level as the people that I work with. And go to the next slide.
What do you guys think about this slide? Any comments or thoughts before we move on? There's a lot here. I'd love to hear from others who've had some experience in this therapeutic alliance.
Yeah, what are your views on the therapeutic alliance in your work? Everybody's kind of quiet.
Hello, everyone. This
Hi.
is Jane. This is Jane from Patio Yate in Fort Thompson, South Dakota. And
Hi, Jean.
I agree with what you say. When I first moved home and established a relationship with the relatives that I communicate, and we refer to anyone, whether it's, you know, clientele, a visitor, a tribal member, we refer to them as relatives. So one of the things that I had to do to develop rapport is I had to reestablish who my family was with them. And then the trust started to come. So in my presentations, I included photos of my mother, grandmother, and great-grandmother, and even great-great-grandparents. And then they knew who I was because I was gone for 20 years to Arizona, then moved back. And I wanted them to know that I honestly and sincerely am there to support them in their wellness and including sobriety. So when I did that, I was like, because now who are you? I really did get those questions. And did you grow up here? You know, kind of on the defensive side. So then I thought, and I was telling them, so I thought, why don't I include that in my presentations? And then that way they can really see who I am and my family and where I grew up. And before I start any presentation, I always say, I want to tell you a little bit about myself and that I'm here to offer support for wellness and for all community members. And I say community members, not tribal, because we still have people who are born and raised on the Crow Creek Reservation, but they're enrolled somewhere else because their grandmother and their mother's enrolled somewhere else. And I always hear that, but they're not enrolled here, even though their families were born and raised here, and that's because of how the government put families on reservations. But then the trust, it started to develop. And then as far as ethical, I always say, I have to, this is from my decades ago being a counselor. And I say, if any of this brings up information, thoughts, history, emotions that are disturbing, you have to remember at the end of the presentation, I'll say, remember who you are, that you're here to help yourself. And that if not, you can help another member. And I say, that's what the Dakota way is, to be a good relative. Oh, I saw a question. Somebody said, what if they don't want to? Oh yeah, there are those, and that don't want to be in recovery, especially those who are court ordered to attend support meetings. And I do say, I am glad you're here. And my groups are so small because my tribal reservation is very small. And so I start talking, and I talk about interest, because to me, I can say, yes, you need to get sober for yourself, your family, your community. But what I found is there were women who confided in me and said, I don't know what else to do. So in my groups that I have under the grant that I work under, I do activities once a month. So I started, and I changed it to, instead of saying, want to learn about opioids, want to learn about Narcan, want to learn about prevention of overdose, I started saying, we're having a beading class to help support learning wellness. We're having a fry bread class. And I got much better turnout. And then I always put in there about prevention, right, and awareness. So and that's my trick as a prevention. And then we open with a prayer. So now I find that a lot of people have forgotten how, or were never taught how to pray. So I always include a session on that. And then I have a handout, and we have a Wopidas song or prayer, a thank you song or prayer. And so I say that, and then I give it to them. And then I always include the serenity prayer. They really appreciate that. And so, and what I've learned that I keep a little notebook sometimes by me, because sometimes when I start getting too many questions, I forget. So I write down, and then I'll reiterate during my presentation and say, oh, I realized, this relative, she had a question. And so that is, so I don't forget everybody. But it's taken me a while to get there. I have to tell you that, people, it's taken me a while to get there. And thank you for letting me talk. I feel better. I had we had a rough morning, so thank you.
Yeah. And here you guys thought we were just, Avis and I were just going to talk at you guys this whole time. We really want to get you guys involved in this conversation.
Get some interaction. I keep a notebook at all times, so I was taking notes, Jean. I'm thinking I'm going to have a fry bread class.
Yeah, sign me up.
Oh, I know, Steve, you're funny. Yeah, and I find that there was actually two ladies who said, I didn't want anybody to know I don't know how to make fry bread. And I said, that's okay. Let's just me and you set up a time, because my schedule does allow it. But yeah, that was actually one of my more successful events. Wow. I do, rather than saying, would you, come listen to me? if I do that, they show up.
That sounds really cool. I know we, from time to time, have had some crafting classes here, and I never thought to, why don't I just do a presentation while we're doing that, you know? So I appreciate your sharing.
Oh, no, thank you. Pidamaya.
Move to the next slide, Steve. This one.
Yeah.
Therapeutic function is positive reinforcement, encouragement, instill hope, build self-efficacy, to provide the patient with support and accurate, genuine empathy, not sympathy, in partnership with the patient, develop goals that are realistic, attainable, and adaptable, and model adaptive interpersonal functioning. So it's letting them feel good about themselves and recognizing when they're making those changes. I've even heard my staff say they notice some of our clients when they start following their treatment program and staying clean and sober, and they'll see changes in them of like, God, that person is dressing really nice now. I said, tell them that they're looking good. You know, they need to hear that. The therapeutic relationship, patient development, again, the patient needs to feel heard. So we have to use our listening skills more than anything. They want to feel understood, accepted, respected, and empowered. And they need to feel that we're genuinely concerned about them and feel that we're working with them, not against them. And feeling that the therapist is, you know, that we're really optimistic about what the potential is that they hold inside them. And also feeling and recognizing that positive change is possible and or that it's occurring. This is our ASAM criteria. This is the book that we use when we are writing up our ASAM criteria and our assessment forms. It talks about what level of care each person meets. So this is, if you're working in this field doing evaluations, this is like one of the must-have books in your line of work.
They are very close to a 4th edition too. I don't know if anyone's seen some of the draft proposals, but there's quite a lot of changes that they're proposing.
Wow.
So we'll have to see even a mixing up of the different dimensions and rewording quite a few of them. So
Interesting.
it'll be very interesting to see if 4th edition catches on right away. So anyway.
The continuum of care. ASAM was they created this criteria to allow for a broader continuum of care. This also differentiates between adult and adolescent care. So there are 2 crosswalks, one that's separate for adolescent when you look at the book, and then there is the adult section of the book. It provides us with a common set of criteria to determine the client's severity and to put the client in the appropriate level of care. That is our support for the recommendation that we make, because they are also at various points in the progression of their addiction. It's not just we can put them in a low level of care, and if we need to move them up, we'll move them up, or if we have them at a certain level, we need to move them down. Say we get people from residential treatment, they step down to our outpatient program, and then we move them out.
Yeah, I always think of ASAM as sort of a supplement to my primary assessment tool. It really can help guide me and have some consistency, and as Ava suggested, have this sort of universal language that I can exchange with those in the field about a patient's current level of care, or perhaps their progress or lack thereof in their treatment experience.
I also think it's a good tool to help educate the client themselves on what level of care we're recommending and why, and what criteria they meet. There are different levels of care under ASAM. So the level 1 is our, we call it our primary outpatient program. And you can set the number of hours for each patient based on what you feel would be appropriate. There is the level 2, the intensive outpatient, and then there are some higher level 2 that could include some partial hospitalization. There is the level 3, and the level 3 has 3 levels. There is 3.1, 3.5, and 3.7, depending on the severity of medical and mental health issues that could be present with that individual. So they have to be medically monitored in residential treatment where there is access to medical staff 24/7, basically. And then there is the level 4, which is medically managed inpatient treatment. And those are hard to find. Here we also have the 0.5 of early intervention. So we do offer early intervention services here for adolescents and adults. So. The dimensions of ASAM.
Oops. That's what I get for trying to hit too many buttons.
Okay, stop.
Sorry about that.
That's okay. The ASAM is commonly rated in a 0 to 4 scale, with 0 being stable or minimal concern, and 4 being seen as a high risk, unstable, and needing significant support or response. So every one of these 6 dimensions is what we look at when we're determining an individual's level of care when we complete their assessment. So we want to know, how are they doing with intoxication and withdrawal? Are they doing just fine? Are they having a really tough time? Do we need to get this person some medical treatment? The second one is the biomedical conditions or complications. So we often ask them if they have any health conditions that could interfere with their treatment or is affecting them right now, or that needs to be treated, and some don't. And sometimes we get people that are presenting with some serious health problems that needs to be addressed. The third one is your emotional, behavioral, or cognitive conditions and complications. Are they doing very well? Are they having significant complications that we need to look at treating those in addition to? 4 is their readiness to change. Some people don't even see a need for it. And some feel like they want some help and they're ready to make that change. 5 is the relapse, continued use, or continued problem potential. I have had people come back and say, I need more treatment because this isn't working. So I just love when I have my clients come in and they're ready to be like, I think I need to go to residential treatment. I'm going to tell you the truth, And so it's good to take a look at that. The recovery living environment, like, are they living in a safe home where people aren't drinking or using substances? Are they continuing to hang out with people that make substances that they've been using readily available? So if they're hanging out with people that are regular users, that might not be good. So sometimes we need to remove them from that environment. And the severity of each dimension can be rated as mild, moderate, or severe. You can go to the next slide. This here.
Just a crosswalk here for folks to see.
This is a crosswalk that, if you look at the top, that takes you all the way across all the levels. As you can see, there's 0.5 all the way to 0.4. And then this is each dimension. And so then there's the wording there for each section that they may be struggling with, if it helps you to write that. I worked at an agency where she may still be using this, I'm not sure, but it was real helpful to me when I was learning to do this. And so I like to share it with the people that I teach as they start doing this work. And the next slide is the rest of it that didn't fit on that one page. So if you get these slides, you can print it out and use it. It comes in handy.
We could get it all in one slide, but it was so small you couldn't, you
Can't
couldn't
read
see
the
it.
wording. Yeah. But if you get these slides, you can print this out and feel free to use it. Like I said,
Yeah.
I highly recommend it. I have a binder here that I keep at my my desk that is like my treatment file, and I have the crosswalk in my binder right in the front for handy dandy use.
Those of you that are utilizing ASAM dimensions and risk ratings, this probably is just a good review. A lot of electronic health record systems. I don't know if AccuCare does this, but they will have the ASAM dimensions and risk ratings sort of integrated into the evaluation process.
AccuCare does do it, and it will let you pick the criteria to give you the placement recommendation.
Yes, that's great to know.
And this is the whole person, patient-centered care. Establishing a therapeutic alliance begins with the patient. The patient's initial contact with a helping professional or the organization. Proper treatment requires proper assessment. Again, use of the ASAM criteria, which is commonly used. As you can see, it's a multi-dimensional tool that assesses 6 major areas of one's life and what level of care they will meet. The whole person patient-centered care, again, this is a multidisciplinary team using the community support systems, the recovery-oriented system of care, selecting a particular theoretical approach that is most likely to result in the patient's improved health. Again, this whole person patient-centered care is also the person-centered therapy, which is where the client and not the counselor directs the treatment process. Go to the next slide. The next slide is about person-centered therapy. This is by Carl Rogers, that developed in the mid-1940s. Therapy does not have to revolve around the therapist's advice, direction, or interpretation. So I often sometimes encounter clients that come into treatment probably for their first time, or maybe more than that, that have this thinking that they're coming into, we're going to tell them what to do or we're going to fix them. So I always have to let them know, this is yours, and we're here to guide you and help you learn some skills that you'll develop your own program. Clients use their own personal understanding, self-realization, and problem-solving techniques. The counselor or the helping professional comprehend how the client sees themselves in the world. So oftentimes in the recovery program, I see many that don't have very high self-esteem, or they have a real negative viewpoint of themselves. So helping them to see the opposite of that, to see what we see. And I tell them, we see things that you don't see. And so I'm the one that's going to focus on all the good things about you, so that you're working from the strength-based approach. The main principles are humanism, which is the innate nature within all humans to achieve our potential and find meaning in life. Having congruence, the counselor is genuine or real. And I really struggled with this when I first started learning counseling skills way back. And gosh, I can't remember what year I started my master's program, but I remember my instructors would always tell me, be yourself, be yourself. And I would kind of struggle because I felt like I had to be somebody different. So once you get to feel comfortable with how you work with people is real important. with unconditional positive regard, we show the clients that they are accepted and that, that we're caring towards them, and having an accurate empathetic understanding to identify with and understand their world. So it's not all about us, it's all about them. So it's again establishing that basic trust to be found in the patient's ability to be able to move in a positive direction.
Anyone have any reflections or thoughts about this sort of relative-centered or patient-centered or person-centered approach in their own practice?
I would like to, this is Jean again. I would like to comment that I've come across people who say, I've been to treatment 3 times that don't work. So I always say, you're the one that makes it work. If you wanted to become a nurse, you would go to nursing school. If you wanted to become a teacher, you'd go to college. So if you want to learn to become sober, you need to go to education classes that help you become sober or clean, which is addiction treatment. And I'm sorry, substance use disorder treatment. I'm trying to get better as categorizing it better. But then I don't know if you know the actor Apiceniquat from, is he Menominee? He's from Wisconsin. And he, I was part of the Native American Journalists Association, and this was 15, 18 years ago, and he spoke. And he talked about how the journalists needed to cover more about addiction recovery. And he said he went to treatment 17 times. And, and you could hear the audience go, oh, and he said, that's what it took for me to become educated in my use. And he says, and then he went on to actually become tribal chairman.
Wow.
And so I always use him as an example. And he talked about the first phases. He was court ordered. Then a few times he tried to go, then something happened and he would quit and go home. But I really appreciated his story and I wish he'd write a book. But that's one example that I use. And then I see it gets people thinking, but I tried to think of persons within our community or in South Dakota that they might know. And I find a lot of people don't talk about that road to recovery that we can share as examples.
That's interesting that you bring that up, because we had a meeting this morning with a program that does podcasts, and it was interesting that the 2 gentlemen running it are in recovery, and that's their whole goal of doing the podcasts, is sharing recovery stories. So we're going to be joining with them and sharing stories of people that we do know, not, that work in our program or in the community, that have stories to share on recovery. So I thought that was interesting that you would bring that up, because it may take several tries. I've seen some people here be like, oh, that person's been here before. I'm like, well, we still need to treat them like this is their first time they're coming in the door. It doesn't matter. It can be a revolving door for some of them, but if we can, like you said, it has to be when they're ready for it and they want it.
Yes.
Okay, you can go to the next slide. We're going to get into some other theories and theoretical approaches. These theoretical approaches are methods for assessing and conceptualizing individual conditions, assisting in increasing motivation to help follow a recovery path. No one approach is appropriate for all. So I like to refer to these as my counselor tool bag of different things that I could do for different situations. So I'm one of those that considers myself I think I wrote a paper on multimodal theoretical approach, which means I do different approaches based on different circumstances, but I'm also duly licensed in mental health. So it just depends on the circumstances of being able to use the different approaches. And also, I always tell my own staff here that over the years of this 20-something years, I also realized that we have our traditional ways, that these theoretical approaches were not created by us, for us. So I like to have an open mind to what I know has worked, for myself and other people that I work with that talk about those cultural approaches that aren't necessarily a particular theoretical approach. I call it a cultural approach. We can go to the next slide. This is a list of common evidence-based practices that are used in the substance abuse field. There is the behavioral theory by Skinner, the cognitive behavioral therapy, CBT, real popular in substance abuse work by Beck, the contingency management and incentivizing. I recently read a lot of research in how this has been successful with stimulant treatment and adolescence. There is also the SBIRT, the screening, brief intervention, and referral to treatment, which is more of a screening tool for people generally that are outside of the program so that they can screen people to see if this is somebody they need to refer to treatment. We have the rational emotive behavior theory by Albert Ellis, also commonly referred to as REBT. And motivational interviewing, real popular in substance abuse. We need to be able to roll with the resistance of our clients in helping them make positive changes in their life. And also looking at the stages of change that includes the trans-theoretical model of, are they in the pre-contemplation, contemplation, active stage, maintenance. So looking at where they are and what their goals are, and also the medication assisted therapy. And somebody just posted all of the White Bison programs, and the White Bison programs have been around as long as I've been in this field. I think when I first started working on my reservation, Don Coyhis himself came to our reservation and provided some training to our staff. And I still attend his trainings every now and then. And our plan for our program is to get the White Bison certification that we can put on our program, as we provide these cultural services as well. And I would like to see the testing agencies acknowledge those more when they do these tests for people that are sitting for the exams.
Clem makes a nice comment too. Clem, you ought to unmute and share this.
Yeah, good afternoon. Can you hear me?
Oh yeah, we got you.
Okay, I just like to use the old adage, plant the seed of recovery every time they come in. Definitely, it doesn't matter if they're there for the first time or if they're there for the 50th time. There's something that can always be learned or reaped or sowed at that time. Definitely meet them where they're at. If their idea of recovery is I'm only gonna smoke marijuana, that whole idea of harm reduction is definitely something we utilize out here. And a lot of the older generations it's either like black or white. You're either in recovery or not. That doesn't work. Definitely with this new generation, harm reduction is definitely a better process. Again, it's not on your list of evidence-based practices, but it's definitely, I would associate that with the medication, the MAT kind of approach. Again, MAT also, a lot of people don't fathom the idea that MAT is actually treatment, because it's substituting one substance for another. Again, there's a lot of stigma, there's a lot of the mentality of the old. You got to be open, and that's definitely my entire focus has changed through my, and I'm gonna date myself since I started working in this field in 1999. definitely my entire concept of recovery has evolved and is continually evolving because we definitely have to meet them where they're at.
Mm-hmm.
Yeah, Clem, did you say 1899? I had
No.
no idea you'd been practicing that long.
He
Yes,
said
1899.
1999.
I couldn't resist, Clem. It was like low-hanging fruit there. You set me up for that, so thank you. Thank you.
I definitely had to learn to become more flexible and definitely to look at it through other individuals' point of view, because I was one of those individuals who was either you're in recovery or not, abstinence or not, and now today that is not consistent with what I believe today, because it just doesn't work.
Mm-hmm. I agree with you, because not everybody's going to get 100% clean and sober. I ran a DUI court program, and I've had men be in the program and say, when I get out of this program, I'm going to drink again. I'm not going to stop. But I'm like, okay, what is that going to look like? Because you don't want to get caught up in the legal system again. I'm assuming you don't want to come back and do a program like this again, and then looking at that harm reduction of less and being responsible with it when they choose to. And I'm with you on the harm reduction, especially in my work now too.
Yeah, and words matter. We know words matter as we address the stigma that's still alive and well, and so it's important to choose our words carefully
Mm-hmm.
and to really be compassionate. So, yeah, that's great. I appreciate the comments from both Gene and from Clem, of course. So thank you.
This is the behavioral theory. This is just some constructs to consider, that all behavior is learned and it can be unlearned. New behaviors can replace old ones. Focusing on the observable, how people act, react, and behave. Less interested in the cognitive emotional states. Believe that behavior represents learned habits. So it's more action-oriented counseling.
We can kind of move through some of these.
Okay. Yeah, I'm looking at the time and where we're at, so it seems like we're jumping ahead. Again, you guys, you will get a copy of these slides, so if you want to take your time and scroll through the rest of these.
Yeah. There's Pavlov's dog. We all know about Pavlov's dog.
Mm-hmm.
If you get a pizza in front of me, I will start to drool. So I can relate.
This is the motivational incentives I was talking about earlier, that I was doing some research on stimulant treatment. And this has been a real popular one in major metropolitan cities where they work with people in providing incentives. And so I've been bringing that up here of, let's add some incentives to what we're doing here. Motivational incentives, more on that. Contingency management, being able to give things for, something as simple as a clean UA, or showing up to all their groups this week, and then, having regular attendance. And just promoting awareness of motivational incentives. Again, it was also shown to be effective with adolescents as well. And I do remember one program on my reservation was doing it for a while, and I just would hear a lot of talk about it, that the clients were motivated to go, to get simple incentives of hygiene products,
Or Starbucks, like Clem mentioned.
Yeah.
Contingency management or motivational incentives is really, it's kind of it's under a resurgence right now. I know SAMHSA has really taken an interest in it. I know at our center we've talked about some of the cultural considerations too, because with the elements of gift giving and using things or gifts to motivate, be careful with that sometimes too from a cultural perspective. So things to consider about this type of contingency management. Let's keep going though.
Okay, keep going.
CBT, we know, you guys know about CBT, just linking thoughts, emotions to behaviors. I mean, that's in a nutshell how I look at CBT.
Mhm.
Very effective.
Okay.
Yeah, and there's, as it relates to relapse prevention.
Yep.
some,
What are your warning signs, your high risk situations? How are you going to handle that?
yeah,
Being able to enhance their self-efficacy to be able to handle those situations. And if they have a relapse, you know, it's a teachable moment. Hey, let's go back and look at the situation. Challenge positive alcohol expectancies. You know, people want to make it look like it's fun, and the lifestyle, having a lifestyle balance. That's just the basics of the CBT. Therapeutic techniques, behavioral rehearsal. Sometimes we can role play some situations of how they might handle someone showing up with some drugs or alcohol to their home, giving some homework, motivational interviewing, relaxation training, systematic desensitization, social skills training can be, you know, as simple as taking them out to go do some activities in the community, and some assertion training, being able to be assertive and say, you know what, I'm not going to do that right now, you know. The rational emotive behavior therapy, it's cognitive oriented, that focuses on changing attitudes and beliefs and negative self-statements. So this also follows that ABC model. What is the activating event, the belief, and the C for consequences. Here we go, REBT. Kind of a little guidance there to look at that. I actually ran into someone last week who said, I attended one of your webinars and you said something, and I printed it out and I put it on the wall, and it's in my office on my wall. And I was just like, wow, that's so cool to hear that you're using some of the materials that we share here.
Mm-hmm.
So here puts REBT in a nutshell.
Yes. There's your ABC component.
Once you memorize that ABC, I mean, you can use it all the time. It's just right there.
Yeah, what is they, you know, one of the things they say is we have around anywhere from 20 to 80,000 thoughts a day, and about 75% of those are negative. I think mine might even be higher than that, but it just, my point is that this idea of cognition is really, you know, it plays a big role in why someone may be struggling or having difficulty in their life. Their thoughts can really dominate even their perception.
I think even more in a cultural perspective of, this is what we learned in our family, was you had a bad day or somebody made you mad, you went, you know, they went and drank, and it wasn't teaching positive coping skills of how to handle those situations. And, you know, I have clients that come right in here and tell me that themselves quite frequently. And here's the stages of change that we were talking about, that when you are doing your assessment, you might want, I mean, when you'll actually put that in your ASAM criteria of where you see this person in the stage of recovery, and being able to educate your clients about this as well.
Does anybody know why how they first used stages of change? What population they used this for? Does anybody know?
Cigarettes.
Yes, to address smoking cessation, but applied in the context of substance use disorders, it can really be an empowering mechanism to raise awareness and to really gauge and allow the clinician to adjust their approach depending on where the patient's level of readiness is. So I think it's a great model to integrate. There's some MI.
Another must-have book in your library. If you do not have it, I highly recommend it. It is a fundamental approach of collaboration, evocation and suggestion, autonomy and self-rule. The 4 principles are expressing empathy, not sympathy, developing discrepancy. You know, there's certain times that you don't have this problem. And so being able to focus on that, and you can apply motivational interviewing to just about any situation that you're working with in the counseling, not just substance abuse. It just happens to work really well with this population that we serve. And rolling with the resistance. Like you said, there's some people that don't want to be here. So how do we work around they don't want to be here, but what is it you really want? What brings you here? You know, well, I need to get out of the court system. So what does that look like? You know, how are you going to navigate through getting out of the court system? And supporting their self-efficacy, what things they are already doing for themselves that they're already doing well. Because I'm like, you know, you're doing something right. You're here today.
Yeah. A patient's ambivalence towards change can really be a wonderful opportunity to explore with them whether they're ready and if they were to make changes, what that would look like. So I think MI interfaces well with patient-centered and some other models that we've talked about.
Mm-hmm. It does.
There's MI continued. And there's a little SBIRT. SBIRT can be self-administered. It can be administered by a non-professional. So it has a lot of advantages in that way.
We've had a recent influx of kids being referred from the school, and our counselor just being so inundated with all these kids that were getting sent to us. And a majority of them were not substance use related, they were behavioral. So we gave this SBIRT to the schools in this area so that the counselors are able to do the SBIRT screening of, do you think this person really meets the criteria to come for a substance abuse assessment?
Anybody familiar with SBIRT? You guys using that in some of your agencies? It works well with MI too. You can really use it as a non-threatening means to screen.
Just some other theories worth mentioning. Social cognitive theory looks at personal factors, environmental influences and behavior, how those interact with each other. Learning from experience and observing other people. The health belief model helps explain why people do or do not use preventive services. That has to do with perception of reward and risk. And the social ecological model considers multiple influences on behavior and states that behaviors both shape and are shaped by the social environment. So, a lot of that has to do. I think another one I'd like to mention is the solution-focused behavioral therapy, brief therapy. I use it frequently. I find it a perfect fit for working with Native Americans because they don't quite often don't participate in therapy on a regular basis. So if you can make it solution focused, it helps them realize that they can learn some problem solving skills through that. Substance behavioral health care in substance use and mental health.
We could spend an entire afternoon talking about this this idea of integrated healthcare. It's coming, it's happening.
I could spend days and weeks.
It's time to break the silos down, ladies and gentlemen.
Yes.
Can we do? Are we going to live long enough, Avis, to see this happen? This is another quote that I think makes sense. A patient's substance use is not the problem, but rather a sign or symptom of other underlying issues driving the substance use. Boy, if I, as a clinician, if I could keep that in the forefront of my mind, it would change the way I engage and build that therapeutic relationship. If I meet with Avis and I've looked over her assessment and I see that she's using cannabis daily and drinking near daily, I may ask her, Avis, I'm really glad you're here. I was looking over your assessment. Tell me what you like about using cannabis. Now that's very different. You know, when I was learning this sort of technique, it was just not part of that intuitive question. I want to go in and say, this is a problem, you need to stop this, there's something wrong here, and I'm going to fix it. That's kind of that old school approach. But if I ask Avis, tell me what you like about smoking marijuana, what am I doing?
There's some reward that is received from the person that's being treated for their continued use of it. Avoidance, coping with, I want to say 90% of the time, coping with trauma until we really can get to the bottom of what it is. And some of people have mental health disorders that they may be self-medicating until they realize that that's what they're doing to avoid some positive coping mechanism.
It speaks to the idea that their use is a symptom. And by me asking Avis what she likes about using can give me some insight and understanding to exploring other ways to address and work through those issues. And that really, to me, is at the heart of what a therapist's work involves. Avis may feel that the cannabis is still working. She may feel it still serves a vital role in addressing her past trauma or her recent grief or loss. And who am I to take that away from her?
I am in an area where marijuana became legal last year and for recreational use. And so I get a lot of UAs now that they just test for marijuana. And I've often referred to this in Indian country as the marijuana maintenance program, It's brought up some issues that we were curious that what other people think that have encountered that same situation. It just depends on where people work, whether it's more accepted or not. That you were talking about using marijuana.
Yeah, I'm just using that really as an example. It really doesn't matter the substance. It really is more about the underlying issues driving the use, whether it's alcohol, cannabis, cocaine, other drugs. But I would be curious to hear from a couple of others about this idea of the substance use being symptomatic rather than the problem.
Mm-hmm. This is where we're talking about the co-occurring disorder. What is it they're using to avoid or cope with coping? Again, this is comorbidity, the presence of one or more disorder. Sometimes I have 3 or 4 and some of my assessments here. So it is really something important to look at and make sure that we treat that. And also the other term used is dual diagnosis. Sometimes we have to look at, oftentimes we really do need to look at the mental illness and the substance abuse. And in my personal opinion, we need to treat both, not just one. There used to be a time where they said, oh, we have to treat the addiction first and then we treat that. But if you're able to provide both, it's highly recommended.
Definitely, when you get somebody into recovery and you get them sober, you get a baseline. You get them past the withdrawal, the post-acute withdrawal, and then you definitely see all of the mental health issues that have been hidden and are emerging, and we're seeing them without the substances interfering or causing or inducing it. So definitely, there's always that question: what came first, the mental health issue or the substance use? And definitely, the comorbidity is there. All of the students that we work with come in with, they have to have a SUD diagnosis, but we're treating co-occurring with every single one of them.
Exactly. Co-occurring disorders, it's the presence of at least two, one being substance use. And these are some real common other disorders that I've encountered in my work: depression, bipolar disorder, schizophrenia, PTSD, and anxiety. So those are pretty common. Again, the PTSD would be coming from trauma. Characteristics of co-occurring disorders, again, repeatedly cycle through treatment, emergency departments, detox, and jail. So these are the people, if they've been here more than once, something is there that needs to be treated. And so often when I write up my assessment, I really emphasize that if this doesn't get treated, they're at a much higher risk than those that don't have those problems to relapse and continue to use.
Oops.
General assessment approach for co-occurring.
Darn it. I'm trying to respond to the chat and advance the slides at the same time. I'm not doing a very good job.
Okay. Again, using your ASAM criteria can be used as a multidimensional assessment. Again, we have AccuCare that allows us to do a multidimensional assessment. Some characteristics of co-occurring disorders: rapid progression from initial substance use to higher levels of severity.
These are great examples. We can just sort of kind of bullet point these. You guys will get a copy of this, and some of you know this list and you could probably create this list yourselves because you're working with patients that, there's estimates that I think the literature says 50 to 60% of patients may have a co-occurring disorder. I think Avis and I have talked about this. I think it's much higher, and maybe in upwards of 75 to 85%. So this is part of the practice that we do, and the patients that come into our centers are often experiencing co-occurring disorders.
Daily here. I see a lot of that here daily. Co-occurring conditions in adolescence. So these are the ages these things start showing up. Parents might start bringing their kids in saying, we're having some problems. I'm seeing this, I'm seeing that. So, I always let them know this is about the age where we start to see these things.
Yes.
Pharmacotherapy, looking at detoxification and withdrawal management, alcohol cravings, replacement, medications, aversive antagonist, mix and agonist, antagonist.
Yeah, these have all been around for some time. Anyone that tells you, you know, medicated assisted therapies are new, you can tell them no, they've really been happening for decades. We just sometimes don't identify them as such.
I'm trying to think when I really got into the medication assisted treatment. Right out of my doc program was when I got into it more.
So again, this is just some information about medicated assisted treatment. There's another acronym that's been used more recently, which is medications for opioid use disorders. And really now the movement is to just really refer to this as medications used during treatment. And not specify what type of medication it is to reduce stigma and people making assumptions. There's some examples.
Disulfiram is for the antabuse. I don't hear of that being used much anymore.
I don't know. We could ask the audience. I don't know. Is anyone prescribing antabuse through your agencies? I always looked at it as kind of a last, you know, option. Prohibiting your liver from processing alcohol just seems dangerous. But anyone still using that, or having their physician or nurse practitioner prescribe that?
I haven't heard of it. I have seen medication used for withdrawals, and that was Librium that they would prescribe.
Mm-hmm. Which is essentially tricking the body into thinking the alcohol is present without the intoxicating effect. So, but it can help avoid life-threatening withdrawal, as we all know. There's some examples of the MOUDs. The implant is taken on more, has become more popular, as well as the injection, the once a month injection. This is important too, just as you use language to talk with your colleagues. Opiate and opioid. Opioid just covers it all. So if you just use the term opioid, you cover all of the different opioid derivatives, whether they're synthetic, semi-synthetic, or natural forms. Boy, we sure have become experts on opioid use disorders in this last 4 or 5 years. So we don't need to spend a lot of time on
Yeah, I think what I've learned is a lot of people that struggle with opioid use disorder were initially had some medical pain problem, broke their ankle, broke their knee, something, and it all started from there because it was popularly prescribed at that time. And now more and more, I see doctors are doing less and less prescribing of opioids, or if they do, it's very limited for a very brief amount of time, you know, maybe just for after surgery, not something they prescribe as frequently as they used to. I see a decrease in that. But I do know people that are on the medication assisted treatment and they are doing well, and they speak highly of how well it helps them. So I met someone who, I think it's been like 7 years she's been on medication, and she's like, I'm starting to get tapered off of it now that my doctor's starting to decrease my doses over time so that I can eventually get off of the medication.
just some information about the use of buprenorphine and naloxone. Again, We're just sort of kind of at the end of our time. We want to make sure we honor everyone's schedules, and just kind of a summary of what we tried to cover today. I know we kind of rushed through that last portion, but we're going to make these slides available to you all. Any closing thoughts or comments about today's presentation or questions for Dr. Garcia or myself? Well, it's certainly been great having everyone on. I am going to post a link to a short survey, and we'd really love to hear back from you. We're looking at revamping how we do these ESAS presentations, trying to make them a little more interactive. So on this survey, there's a couple of spots where you can give us a short answer feedback, help guide us a little bit. We'd love to hear from you. So if you can, take a few moments to fill that out. We'll reach out to you via email, post-event, and you'll have another opportunity to do that. So thank you again. Thank you so much, Avis, for coming on and spending some time with us and reviewing this really important information. Great to see everyone. Clem, thanks for sharing. Great to have you guys on. Until next time. Please stay safe, stay healthy, and most importantly, stay connected, folks. Okay?